everyone. I am an attending surgeon of the First Hospital of China Medical University. Today, we are going to talk about some problems affected almost everyone, while most of them avoid to seek medical attention until it is too severe. Rectal prolapse is the protrusion of the rectal mucosa or the entire rectum through the anal opening, while mucosal prolapse is more common in children. Full-thickness prolapse occur more commonly in adults. Increased intra-abdominal pressure, example, excessive strain as a result of constipation, and the weakness of the pelvic floor muscle, example, as a result of old age, multiple pregnancies, are risk factors for rectal prolapse. Cystic fibrosis, moreover, is an important risk factor in children. The most commonly presenting complaint is a painless rectal mass that appears on staining. Other symptoms include fecal incontinence and constipation and proctitis ani. Rectal prolapse can be caused by several medical conditions, include nerve damage. If nerves that control the rectal and anal muscles are damaged, rectal prolapse can develop. These nerves can sometimes be damaged from pregnancy or during a difficult vaginal birth, a spinal injury, surgery in the pelvic area, weakened anal sphincter. This is the muscle that allows stool to pass from your rectum. Common reasons for this muscle to weaken are pregnancy and childbirth, or increased age, chronic constipation. The strain of chronic bowel movement problems can make your rectum more likely to move down from its location. Strain while having bowel movements, if done often over a period of years, can also cause rectal prolapse. While not directly linked to rectal prolapse, some conditions may increase the risk for it, including cystic fibrosis, diabetes, chronic obstructive pulmonary disease, parasitic infections, a hysterectomy. Women over the age of 50 are also at an increased risk of rectal prolapse. In adult patients, treatment of rectal prolapse is essentially surgical. No specific medical treatment is available. Children, however, can usually be treated non-surgically and by managing the underlying condition. Which repair constitutes the best treatment is the main controversy in surgery for rectal prolapse. The goals of surgery to correct rectal prolapse are threefold. First, to eliminate the prolapse through either resection or restoration to normal anatomy. Second, to correct associated functional abnormalities of constipation or incontinence. Third, to avoid the creation of de novo bowel dysfunction. Multiple operations have been developed to achieve these complex threefold goals, each with various strengths and weaknesses, underscoring the importance of careful patient selection and thorough patient counseling when choosing a surgical approach. The most common cause of anorectal separation is non-specific glandular infection. Other less common, also not necessarily really cause, include Crohn's disease and hidradenitis suppurativa. The abscess represents acute manifestation and the fistula, the chronic sequela. Anorectal abscess generally originate in the intersphincteric space. The infectious process may remain isolated within the intersphincteric space, or it may extend vertically upward or downward, horizontally or circumferentially. Abscesses are generally classified into perianal, rectal, intersphincteric, and supralevator. Intersphincteric abscess is limited to the primary site of origin. This abscess may be asymptomatic. However, classically, the patient will present with pain out of proportion to physical examination findings. Downward extension results in a perianal abscess exhibited by a radial swelling at the anal margin. Upward extension may result in a supralevator abscess. This abscess may be difficult to diagnose because the patient may complain of large pelvic or anorectal discomfort, and there is a lack of external manifestations. Supralevator abscess may also result from pelvic infectious processes, such as diverticulitis. In rare instances, this may extend downward into the ischial-rectal or intersphincteric space. Horizontal spread may traverse the internal sphincter initially into the anal canal, or externally across the external sphincter into the ischial-rectal fossa, forming an ischial-rectal abscess. This abscess may become large as external physical examination findings may be subtle, and the infection may initially or insufficiently be treated with only antibiotics, allowing expansion to the roof of the fossa or through the pelvic floor into the supralevator space. Patients may complain of pain and fever before an obvious fluorescent mass is detected. A complex horseshoe abscess may result if the other of the intersphincteric space, supralevator space, or ischial-rectal fossa. Acute anorectal abscesses should be incised and drained at the time of diagnosis. The location and method of drainage are determined by the location of the abscess. Recurrent abscesses may result if there has been inadequate drainage, presence of fistula, or underlying immunosuppression. Antibiotics and abscess culture have a limited role in the treatment of uncomplicated anal suppression, but should be considered in patients with immunosuppression, systemic illness, or a history of prolonged and frequent antibiotic use. Fistula in anal can develop in approximately 40% of patients during the acute phase of sepsis, or even be discovered within 6 months of initial therapy. Fistulas are categorized by the Risk-Parks classification. The most common anal fistula is an intersphincteric fistula. Most frequently, the fistula traverses directly downwards to the anal margin. In some cases, however, the tract may travel upward in the rectal wall, with or without a perineal opening. In transsphincteric fistula, the tract travels across the external sphincter and into the ischial-rectal fossa, terminating at the perianal skin. It passes through the muscle at a low level. It is uncomplicated and treatment is relatively simple. However, if it involves upper 2/3 of the sphincter, repair is more complicated. Suprasphincteric fistulas are rare and can be difficult to treat. With these fistulas, the trajectory is above all the muscles of importance to continence. Furthermore, the fistula may have an additional extension into the pelvis parallel to the rectum. Finally, an extrasphincteric fistula is also rare and often results from iatrogenic injury. It travels from the perineal skin to the rectal wall above the levator ani. The tract is completely outside the sphincter apparatus. Treatment often involves the need for a colostomy. Adequate and appropriate treatment is dependent on correct classification of the fistula and identification of the internal and external openings, the course of the tract, and the amount of sphincter muscle involved. Surgical treatment remains the primary modality of treatment for non-inflammatory bowel disease-related fistulas. A draining seton is placed loosely through the tract to facilitate drainage of any sepsis and to preserve the sphincter. This may be converted to a cutting seton, which is periodically tightened at regular intervals to slowly cut through the involved sphincter muscle and to promote fibrosis to avoid disruption of the sphincter and the resulting incontinence. Today, we just talked about the common anorectal disease, actually still lots of uncommon ones. If any questions, I will always be there for you. The First Hospital of China Medical University. Thank you for your attention.